So now let's talk about some funkier stuff. And at first glance, you look at it and you're like, might be a STEMI. Might be ST elevation. Am I? I see ST segment elevation, but it's an imitator of a STEMI. We do have ST elevation, but it's not an MI. So let's talk about some imitators of STEMIs so that we're not calling a code STEMI on something completely different. The three big imitators are left bundle branch block, pericarditis, and benign early repolarization. Now, we've already talked about left bundle branch block and how that pulls up the ST segment normally, and how we can use Scarbosa criteria to differentiate, or I should say, help diagnose a STEMI in the presence of a left bundle branch block. So, left bundle branch block on its own, it's kind of maybe look like a STEMI at first glance. There's going to be ST elevation, and then we've got our Scarbosa criteria that we've already covered. That's going to tell us that, yep, there's a left bundle branch block, and yes, there is also a STEMI going on. Now let's talk about pericarditis and benign early repolarization and what they look like on the EKG. Next up is benign early repolarization, because this is totally normal. But at first glance, at a 12 lead, you might say, I see a STEMI, but it's completely not normal, hence the benign part of it. There's just some early repolarization going on. This happens in completely healthy patients, asymptomatic patients, so you might do a 12 lead just for funsies, just in case, on a patient, and they're not complaining of chest pain, they're not complaining of shortness of breath, nausea, vomiting, any of those typical cardiac complaints. They have a healthy record, no significant past medical history. So healthy patients, asymptomatic patients. And what this is just J point elevation. There might be a notch at the end of the QRS. Sometimes there is, sometimes there isn't. But benign early repolarization, hallmark sign of it is this kind of concave upward kind of slope scoop into the T wave. And we'll pull up a 12 lead here in a moment. But this kind of scooping up into the T wave with a J point elevation. And we're going to see this throughout the EKG. It's not just going to be in a couple leads, not just in a couple contiguous leads. It's not just going to be 2, 3 AVF. It's not going to be V1, V2. We're going to see this all over the place. So an otherwise healthy patient with no symptoms is probably not having an MI in every single region of their heart at the same time, right? So we see this all over the EKG. We see these concave upward slopes into the T wave, maybe or maybe not a notch at the end of the QRS. And then with this, we don't have any reciprocal changes. So it's not like I'm seeing this in the lateral leads, and I'm seeing it in the inferior leads. Those leads are reciprocal to each other, so I should see some negativity in my inferior leads if I see positivity in my, or elevation in my lateral leads, and vice versa, but I don't see any reciprocal changes. But what does this kind of concave upward sloping into a T wave look like? Well, it looks exactly like this. We have a little bit of ST segment elevation. So at first glance, you might think STEMI, just at first glance. But if we look at it for another 10 seconds, we see that it's all over the place. It is in just about every single lead. AVL, not so sure of, right? Maybe a little bit. AVL super small. But we've got this scooping, sloping, even AVR, it's going to be like a negative slope, negative scoop into the T wave. So it is everywhere. So is my patient having a heart attack in every single region of his heart at the same time? Probably not. Especially if he is up and talking to me in asymptomatic and 23 years old and otherwise healthy. So we've got that all over the place, and on this EKG, we do have some of that notching. Especially V4, you see that little notch right at the end of the QRS complex. It doesn't always happen. You don't always see it in benign early repolarization, but those two things put together, hallmark sign being that concave upward slope into the T wave, on top of that notch at the end of the QRS complex, it's going to tell us that this is benign early repolarization, and I shouldn't be calling a code STEMI into the hospital. Next up, as an imitator of STEMI, is pericarditis. So we've got an inflammation of that pericardial sac. What differentiates this from a heart attack, let's say, we've got a patient with chest pain, but that chest pain is reproducible. We can cause it to be worse just by pushing down on the chest, just by your patient breathing, maybe. So it's reproducible chest pain versus non-reproducible chest pain that we see in the cardiac patient, that we see in our heart attack patients or our acute coronary syndrome patients. On top of that, if we look at our 12 lead, we're going to see diffuse ST elevation. So it's going to be ST elevation, again, not just one region, not just two regions, but like just about every region. It doesn't have to be every single lead, it just has to be diffuse. So again, is my patient having a heart attack in every single region of his heart at the same time and talking to me? So do we have blockages in every single coronary artery, and he's still talking to me? Probably not, right? So we have diffuse ST elevation, okay? I look at AVR, so this is another way to use AVR, and I have ST segment depression in AVR. Another classic finding of pericarditis, we're going to pay attention to the PR segment itself. So the PR segment, that little teeny tiny segment in between the P wave and the start of the QRS, we're going to see PR depression. So diffuse ST elevation, see ST depression in AVR, and then we might see PR segment depression. And this EKG prints out for you. Again, at first glance, looks like might be a STEMI. And you might be thinking STEMI. But we have ST segment elevation everywhere. Is your patient having a heart attack everywhere at the same time? Probably not. So ST segment elevation everywhere. V1 doesn't look significantly elevated, but everywhere else we've got elevation. We do have some notching at the tail end of that QRS complex, so you might be thinking, well, why isn't that benign early repolarization? Well, let's look at our PR segments. And our PR segments compared to baseline. So we go, especially in like lead 1, lead 2, and AVF, and over here in these precordial leads, and V2, V3, and 5, 6. Right? Those PR segments are depressed. And we have ST segment depression in AVR. So we have ST segment elevation everywhere. So if we think everywhere, we're thinking either benign early repolarization or number 2, pericarditis. Patient presentation, patient history is going to tell us which way to go on that one 99% of the time. But even just looking at this static 12 lead, I don't know anything about this patient's history other than it was a confirmed pericarditis. Other than that, we do see maybe some concavity to it, and that little notch is like, well, maybe it's benign early repolarization. Well, that AVR ST depression tells me otherwise, and that PR segment depression tells me otherwise. And I'm guessing if you were to talk to this patient, they'd be complaining of chest pain and have some medical history behind that.